So thank you very much to the Focused Ultrasound Foundation. It's a pleasure to join everybody here at this workshop. My name is Nir Lipsman. I'm at the University of Toronto in Sunnybrook, and I'm pleased to discuss our early experience in glioblastoma focused ultrasound trials. So the field of focused ultrasound is rapidly expanding and in fact exponentially growing over the last 30 years, where if you look at the publications per year, there's been exponential growth. Much of that has been driven by two dominant inflection points, which is the use of focused ultrasound to open the blood-brain barrier, first demonstrated in animal models, and then the first reported attempts of using ultrasound to thermally ablate brain tumors. So neuro-oncology has really driven progress in this area. We'll be talking about BBB opening specifically, and of course the BBB is a major challenge for the delivery of therapeutics to brain pathology. Many different attempts and different technologies have been used to try to overcome the BBB, from convection-enhanced delivery and bulk flow to molecular mimicry approaches to impregnated polymers with chemotherapy. And what we're talking about today is the use of intravascularly injected microbubbles, which take up ultrasound energy and essentially cause a mechanical disruption in the cells comprising the blood-brain barrier. This is a less invasive approach that is spatially targeted. In the University of Toronto at Sunnybrook, we work very closely with Insight Tech on their Exoblate helmet. Several features here lend itself quite well for real-time image-guided BBB opening. These include a stereotactic frame-based procedure using cool degassed water for the medium for ultrasound to travel through, as well as multi-source transducers lined inside the helmet with a procedure that's done under direct high-resolution MR guidance. So this combines to form a stereotactic, anatomic, spatially and temporally precise approach to image-guided access to brain pathology, of which brain cancer is among the most prominent examples. So we started this work back in 2015 when this was our earliest experience demonstrating that we can use focused ultrasound to reversibly open the blood-brain barrier in a human patient with glioblastoma. We showed at the time that doing so was possible, was technically feasible, was safe, and in fact was temporary. And this is an example of one of those patients demonstrating the posterior rim of the resection cavity lighting up with gadolinium. Gadolinium is about 1 kilodalton in size, only going to places where the blood-brain barrier is disrupted or open. And we leveraged that experience to go on to a phase 2 trial. This is a multi-center trial being done at several centers around the world, and you'll hear from some of the PIs elsewhere doing this study as well. And here we're using ultrasound to enhance the delivery of temodar, temozolomide, to the resection cavity of patients undergoing maintenance temozolomide for 6 months. So these are the MRIs of the first 9 patients. And what we were able to show here is that we can, in a conformal way, target the resection cavity of these tumors in an awake, non-invasive day procedure. So we found that the duration of treatment has gone significantly down in the last several years with technical advances in the field. So significant improvements in the phase 1 and 2 trial, allowing us orders of magnitude greater volumes of BBB opening in a much more controlled and conformal way. So we have found this to be a fairly well-tolerated procedure, and in this case, successfully able to show that we can open the BBB opening repeatedly. In addition to de novo GBM, we have a trial ongoing looking at carboplatin delivery in patients with recurrent glioblastoma. This is an example of one of our patients. This as well is a multi-center trial currently ongoing. So recurrent GBM, one of the major challenges in the neuro-oncologic field, not only because this is a pervasive and highly malignant and deadly form and turn of events for the tumor, but also because there are very few effective treatments for this. The thought is that delivering carboplatin to the resection cavity can potentially help mitigate and enhance progression-free survival in these patients. As part of the phase 1 proof of concept feasibility study, this is one of our patients. And here too, we were able to show that we can open large volumes, both within and near the resection cavity of a recurrent brain tumor in an awake, non-invasive day procedure that took approximately 2.5 hours. So again, when you look at the volume of BBB that's being opened from phase 1 in the feasibility study, which is approximately 1 to 2 cubic centimeters, now within about 5 years, we can open more than 65 cc's of the blood-brain barrier. You can see significant advances in the technology with a much more efficient procedure. So this trial is now ongoing. We have a very strong interest as well in metastatic breast cancer and in other metastatic lesions, specifically using focused ultrasound as a targeted approach for the delivery of immunotherapy. These are 2 patients in a trial looking at focused ultrasound enhanced Herceptin delivery to the posterior fossa in patients with otherwise progressive intracranial disease. We've been able to show so far that in the small cohort, we can safely and reversibly open the blood-brain barrier and do so in highly eloquent regions of the brain, in the posterior fossa, specifically at the level of the brainstem, near ventricular surface, and near cranial nerve nuclei as well, extending all the way to the cerebellar cortex. You can see here in patient number 2. So these 2 are procedures that were done as outpatient procedures, and patients tolerated it very well. The next steps here are going to be to combine with other kinds of chemotherapy, as well as potentially labeling the chemotherapy so that we can directly visualize its passage across the BBB and engaging the target in the brain. So what have been some of our experience so far in BBB opening applications? So we've now treated over 150 treatments for multiple indications, not only in neuro-oncology, but in other indications as well, including the neurodegenerative conditions. What have been some of our experiences? Well, overall, this appears to be a well-tolerated frame-based procedure, and we have not encountered so far any serious adverse events. In the vast majority of patients, these are outpatient procedures. The acquisition of T2 star images in order to look for blood products is a key part of the procedure. It is a safety mitigation strategy, and the presence or absence of T2 star changes, which in the vast majority of patients go away by the next day, are important in order to fine-tune the technical aspects of the procedure. We know that we can now target large multi-target volumes in the brain and even target eloquent cortex, including motor, sensory, and other regions of the brain safely. In terms of elements of the procedure that are key, positioning relative to the tumor, similar to the gamma knife experience, is important. If very large tumors, laterally displaced tumors may require repositioning of the helmet, so positioning is important. Intraoperative imaging is very important, again, as I mentioned, for a safety mitigation strategy, especially in your eloquent regions where you want to avoid T2 star or extravasation noted on GRE sequences. Judicious use of gadolinium is key. We tend to use half dosages prior to the beginning of the procedure, as well as for planning with the remaining half after the procedure to confirm BBB opening. For oncologic applications, we target the flare and the tumor rim approximately 1 to 2 centimeters beyond the resected target, targeting areas that could not be accessed surgically. And postoperatively, we use contrast-enhanced imaging and flare, as well as T2 star, once more as a safety strategy, but also to monitor patients long-term. One of the key questions for the field is going to be timing of chemotherapy relative to focused ultrasound, whether it ought to be on board at the time the blood-brain barrier is open, or whether there is a window after the procedure in order to deliver the chemotherapy. This is something that remains to be seen. We in Toronto are administering chemotherapy concurrent with blood-brain barrier opening or shortly before sonications in order to potentially maximize its onboard concentration. What are some of the next steps in our view of cancer? Certainly, there's strong interest in the community to tackle both primary and secondary brain tumors, given the flexibility of this technology. There's very strong interest with collaborators both here in Toronto and elsewhere to tackle malignant brain tumors in children. And now we have demonstrated that we can target even low down in the areas of the brainstem with this technology. We are interested, of course, looking at the full spectrum of neuro-oncologic disease from upfront, maintenance, and recurrence. And a key aspect of this is looking at the diagnostic potential of ultrasound, moving beyond just its therapeutic applications to see whether we can pick up peripheral biomarkers of whether it's metastatic or primary disease by enriching cell-free DNA to permit that kind of analysis. So that work is ongoing, and we've recently published some preliminary proof of concept data that this may in fact be possible. There are several questions remaining in the field, and I won't go over these in detail, but suffice it to say that every aspect of the procedure, from the patient and disease factors to the actual technical parameters, which therapeutic ought to be delivered, and follow-up, all of these are key questions for us as a field that we're going to need to tackle in order to determine what role, what place focused ultrasound will have in neuro-oncologic disease. These, in my view, are tremendous opportunities. Each one of these question marks are key to determine, again, the feasibility of this technology, and something that ought to be the agenda for the field for many years to come. With that, I'll conclude, and I just want to extend my gratitude to the tremendous team that I'm privileged to work with here at Sunnybrook. Thank you to Dr. Kalervo Hinanan at Sunnybrook, our operations team as well, and all the graduate students and collaborators working with us in all of our trials at the University of Toronto. Thanks very much.